So this is about orthopedics. Let's see the topics. The reading time is around 50 minutes. Bone infections, common fracture etiologies, open fracture joint replacement, Perthes disease class presentation from Study Medic. A nice compilation of this. I really appreciate their work. I'm just recording it for the purpose of reading afterward, as it's difficult to print this, so I have to record with the camera. So what about this orthopedic surgery and bone infections? Basics of the bone and joint infections are: introduction is orthopedic infection can present acutely with a major systematic upset, local inflammation and purulence or with gradual bone destruction leading to loss of function and slowly evolving local symptoms in presence of absence of systemic features. So bone and joint infection cause a substantial burden of the complex morbidity. Acute infections can be life-threatening and diagnosed or incomplete treated and can persist for decades, causing pain and interference with activities. What is the epidemiology? Then bone joint infections from hematogenous spread. They can be from the spread from the blood and increase due to may be increased due to implant for joint replacement and fracture fixed in an important source of injury. Immunocompromised patients are another increased source of infection. Pathology. What is pathology? Acute osteomyelitis occurs when pathogenic organisms cause infection and may from abscess. Infection may track down to the cortex to the periosteal elevation and soft tissue extension. This process will devascularize the bone, causing bone death and characteristic feature of osteomyelitis. Bacteria can cause adherence to the dead bone or implant surfaces, forming a complex community in polysaccharides known as biofilm. These bacteria alter their metabolic state, making them more resistant both to the host immune and the antibiotics. Toxic and lytic enzymes from bacteria cause early damage to articular surfaces. The infected bone reacts to the infection by separating the dead fragment of the bone, that is called a sequestrum, forming a sinus to the brain to drain the pus and discharge small bone fragments. New bone is laid down around the infection, that is called as involucrum. So you can see it in this figure. In children, the hip and ankle, wrist and shoulder have intervertebral physis, so allowing organisms to enter the joint and cause septic arthritis. Organisms escape from the vessels in the physis, where blood vessels are slowest, and abscess occurs in the metaphysis. This is the abscess in metaphysis. Pus escapes under the adjacent periosteum, elevating the periosteum, that is seen on X-ray. So you have seen the sequestrum is elevation and involucrum is the dead bone inside. A septic arthritis infection may follow aggressive bacteria, particularly neonates. In some joints, hip joint, ankle, and our growth plates are covered by the joint capsules, so pus can extend into spaces leading to septic arthritis. Radiograph. This radiograph shows infection of the fever with large central sequestrum and well-developed involucrum. Diagnosis predominantly clinical and confirmation using other tests. Diagnosis is needed in children, therefore children with unexplained fever. What is biomarker? The raised inflammatory markers. WBC counts are raised, CRP is raised, and acute characteristics of acute infection. Imaging is plain radiograph, dead bone, periosteal reaction, involucrum formation, losing of the implant. However, early stage acute infection, plain radiograph may be normal. Serial radiography is most useful in charting onset of the symptoms. Ultrasound is ideal for identifying the soft tissue infections. Computerized tomography help to assess bone union after uninfected fractures. Isotope. What is the imaging? Isotope bone scans are used, very limited, and they non-specific and give no information which may diagnosis. The combination of 18F fluorodeoxy glucose positron emission tomography, also called as 18FDG PET, with CT scan allows localization of acute infection and chronic osteomyelitis, facilitates planning the surgery. Magnetic resonance imaging scanning is done in investigation of choice, is highly sensitive and specific to all components of the disease. However, it is adversely affected by the metal implants. Overestimate. So what is the microbiology? You see, most common organism is Staphylococcus aureus, most common cause of bone joint tissue infection. Now these are the different organisms: Staphylococcus aureus, commonest. The pictures are very small and I cannot enlarge this because there is no option of making it. That's why I have to record it, and even you cannot see the bigger size. So this is a table. Organism most commonly involved in the bone and joint infection. Gram positive is Staphylococcus, Streptococcus, gram negative Enterobac, and mixed is anaerobic. So what is the management of bone infections? Successful treatment relies on careful multidisciplinary treatment, pre-operative patient assessment and clinical staging, full discussion with the treatment options, Operative exposure of the multiple deep bone samplings, excision of the non-viable tissue, intravenous antibiotics, dead space management, post-operative functional rehabilitation, continuation of antiviral therapy. Septic shock needs treatment without delay and antibiotics should chosen empirically based on the local guidelines. Then elective surgery for osteomyelitis, antibiotics should be stopped at least 2 weeks in advance. So antibiotics should be stopped at least 2 weeks in advance in elective osteomyelitis. Agents such as co-amoxicillin and ceftriaxone are appropriate for most operative infections. Vancomycin provide for methicillin resistance. So what is this native septic arthritis? Bacterial infection of the native joints, incidentally 4 to 5, 10 per 1 lakh population. High incidence also with socioeconomic deprivation and affects patients at extremes of the age in context to the underlying bone abnormality. Joint infections may arise as a result of hematogenous dissemination of bacteria from another focus. Endocarditis result direct inoculation of the direct extension from the infected source, traumatic wounds. So risk factor of native joint septic arthritis, extremes of the ages. Underlying joint abnormalities, especially rheumatoid arthritis, immunocompromised, diabetes, immunodeficiency, joint instrumentation, intravenous drug abuses, indwelling catheters, bacteremia, acute subacute history of hot swollen joints, children with history of recent trauma, joints immobile. In children and adult, knee joint is most commonly frequently affected. Neonates, hips joint is commonly affected. Now what is the diagnosis? Aspiration biopsy of intraarticular fluid will allow gram stain to be performed and then culture the organism. However, results are delayed by the time. High WBC count, high neutrophil count predominance may be indicator for infection. However, inflammatory condition can also raise to this. And crystals may be seen in infected joints for as well as gout and pseudogout. Limited sensitivity and specificity of direct microscopy of gram staining to obtain positive culture. Surgical management, medical management rarely indicated. Medical treatment alone is rarely indicated in joint sepsis. Prompt surgical drainage is very important. Inadequate clearance may lead to chronic infection. What is medical? 4 to 6 weeks IV antibiotics for 2 weeks. Sparse data summary. Most common at the extremes of ages. Rheumatoid arthritis and association immunocompromised patients. What is the epidemiology? Incidence of prosthetic joint is less than 1% per joint, where hips at a stronger risk. Risks include obesity, skin, and all these. Infection complicates 3 to 5% of the fracture fixation, tibial fracture. Clinical feature early, within 2 weeks of injury is delayed. Then early infections may be delayed. You get due to low virulence organisms. Late infections may be present in indolent clinical syndrome or discomfort. Startup symptoms are commonly characteristic. Diagnosis: leaking wound implants. Gold standard for diagnosing is culture of the organisms. Multidisciplinary treatment is required. Surgical infection disease, optimization of the medical comorbidities has to be done first. Debridement and antibiotic implant. This is DIR, debridement, antibiotic implant retention, possibly only if prosthesis is well fixed. So surrounding infected tissue has to be seen, cannot be achieved by arthroscopic surgery. Good soft tissue coverage is essential. Following debridement patient is after debridement patient cannot be achieved by arthroscopic. So following debridement patient is treated with long-term antibiotics. Prolonged infection-free interval is required. 2-stage joint revision. A thorough excision is undertaken. All the imminent loose foreign bodies removed. Antibiotic pregnated spacers may be implanted. This is temporary measure and cannot withstand full stage weight bearing. Patient is treated with oral antibiotics or IV antibiotics for 6 months. Single stage joint revision surgery. A procedure is same as above, but removal and reimplantation are undertaken in the same session. It's very difficult. Healthy soft tissue around the implant has to be there. Some centers consider single stage revision when less florid signs are there. Joint removal or fusion if the patient, for the patient who has intolerable symptoms, but surgical strategies outlined technically not possible. So removal of the prosthesis without reimplantation, palliative, for example, girdle stone arthroplasty and all this. Suppressed therapy with androgen. Patient who are not medically fit, you have to go for. Well-fixed prosthesis may be debrided, treated, antibiotic implant retained. Loose prosthesis may be removed, replacement at the initial surgery allowed, delay to allow infection. So what is acute osteomyelitis? This is present like septic arthritis and short history of pain, loss of function and systemic update in adults. Vertebral column is the commonest site of. In children, long bones are more frequently affected, and there may be swelling of affected limb. Diagnosis early phases 2 to 3 days radiograph may show normal, but MRI will show edema and periosteal elevation. 5 to 7 days radiograph may show abnormalities in osteopenia and periosteal bone reabsorption. WBC count CRP is raised. Acute administrative with antibiotics and diagnosis in between 2 to 3 days of the symptoms. There is no dead bone on the imaging and no adjacent septic keratitis. Culture results from the guide therapy and blood culture is done, and the pus culture. Limb should be splinted with the good analgesic intravenous antibiotic therapy depending on the progress. If the patient does not respond well, limb deteriorates on this imaging in progress. If the patient surgery is indicated, then with prompt treated acute bone infection, good prognosis. Presence in children toxemia and unwillingness to move the lump may affect the vertebral columns. So this is acute AIM. What is chronic? This is a serious condition which affects the patient for decades. Chronic infection is present in multidisciplinary who has skills to deal with the aspects of condition. The plain excision, soft tissue substrate, bone destruction, and surgical excision management is Cerny matter classification helps to define the feature of infection in the bone. 4 stages to relate to the general condition of 3 groups. Patients can be divided into 3 physiological host types. A is no active concurrent disease. B is compromised hood. C is comorbidities are present. So these are the 3 different groups. Along with Cerny matter classification is done. The interaction between the patient's health status and extent of the bone infection greatly affects the outcome of the children. In chronic, it is helpful to address the medical condition which may impair when stage 1 is medullary. Only cancellous bone is involved. Excision of the dead bone can be carried by intramedullary reaming or windowing of the cortex. This result defects may filled antibiotic loaded cement beds. Now stage 2 is superficial and stage 3 is localized. So medullary, superficial and localized. Only cortical bone is involved and requires excision. It follows skin ulceration, maybe large defect and require complete excision. Free muscle flaps can be used. And stage 3 is localized. It is area of the dead cortical bone and medullary radical excision is done. And stage 4 is diffuse, and this entire circumference of the bones around the tissue, all infected non-union stage, must be segmental stabilization by external fixators as required in this reconstruction management. So after summary, patient should be given antibiotics 6 to 12 weeks, antibiotic long course antibiotics given. Chronic disease requires specialist surgery with excision, and host diffuse status is important.